And I'm going to do my best to go quickly so we can stay on track time-wise with the other track. But my name is Molly Vocino. I'm a social worker at the Sidney Kimmel Cancer Center at Jefferson in Philadelphia. And yes, round of applause for my amazing team. My amazing team. And so I support the melanoma team there and all of the ocular melanoma patients that come through, and run one of the support groups with the MRF as well. So I've gotten to connect with a lot of people near and far who are living with this and helping navigate their families with all of this. Um, and so wanted to devote some time to discuss how we talk about this diagnosis with the people we love, and also with some of the other people that we encounter in our lives, why this is difficult, and ways that we can help find the words to talk about all of this. So why is it difficult to talk about cancer? This is, probably nobody in this room has a non-answer for this, but it's often hard to know exactly what to say, what words to use, how much detail to give, depending on who it is you're talking to, what the question is that's being asked, what relationship you have with that person. And while there is power in the narrative and being able to gain control and authority over the way that you deliver some information about your diagnosis or your loved one's diagnosis, that power can also, lead to responsibility and can lead to challenges in bringing up emotion in situations or scenarios that you might not have expected to. And it's also hard to predict how others are going to react or how you might emotionally react to having some of those conversations, especially if they aren't planned or if they come up spur of the moment. You run into somebody at the drugstore and they said, "Oh, how is so and so doing?" Or "How are you doing?" Or you run into somebody in the wake of maybe an enucleation surgery. They notice that you're wearing a patch or that you've gotten a prosthetic and they say, "Oh, what's going on there?" Maybe that's not the time or place you want to get into it, but these situations are sometimes thrust upon us. And in those environments, it's hard to know how people will react, how much information to give. You also, in a lot of cases, don't want to unnecessarily upset or cause distress in the people around you. And so it can be hard to know how much information to share about the things that you're worried about, how to talk about the things that you're worried about without overburdening emotionally the people around you. You also might not want to place your diagnosis at the center of your world by talking about it all the time, or it being always the constant source of conversation with the people around you. And finding that right balance. I think so much of this is about finding balance and figuring out, to what degree is it helpful for you to talk about it? For what degree is it helpful for other people in their life to get updates from you about it, to feel like they're needed and that they're providing an outlet for you? And also for you, not overburdening them. It's this really difficult dance to find the right place. And maybe you're just not ready. Maybe there's still a lot of information you don't know. And so figuring out how to answer questions can be really difficult. Certainly, there's an unknown about how sharing information is going to impact your relationships. Ali on the panel earlier was talking about navigating these conversations in the context of dating, new relationships, new friendships. Those can be platonic, romantic, professional. How will this information change the dynamic? And there's certainly a profound grief response associated with all of this. Grief is not only just about the anticipated loss of a life, but in all these other ambiguous losses that come along with having cancer, having a loved one with cancer, having any kind of serious illness, or really any kind of major life change, is something that brings about this grief response, and figuring out what to do with that emotion can certainly complicate your ability to talk about it. Overall, there's no right or wrong way to talk about your illness. Certainly, a diagnosis like ocular melanoma can present even more difficulty because of how rare it is. It's not breast cancer or lung cancer, where there's more of a sort of widely accepted knowledge base and understanding of what causes it, how it presents in the body, what the treatment options are, and what this looks like. Most people may not or have not heard of it. Some doctors may not have heard of it. Going for that annual checkup with your primary doctor in the wake of a diagnosis like this can be a challenging visit if that person has no knowledge of that either. So you're suddenly educating in the position and the burden of educating your other healthcare providers. Other people in your life or that hear about this may then over or under catastrophize the meaning of this diagnosis. And that can lead to a disproportionate amount of Google searches about what's going on, which again might lead people to be exposed to information that may or may not apply to you or your loved one around your diagnosis. It may lead people to either, place more fear on you or themselves around what this means versus someone else who may sort of underrepresent the importance and significance of this diagnosis and not realize how much it's causing an impact on your life. So there's certainly that added burden in educating others about this when it's a rare diagnosis where most people don't know about it. So how do we talk about this? One thing we know is that when it comes to distress in general, just in life, talking about it, hard stop, talking about it helps to relieve that distress. Having an outlet, a space that you can say out loud the things that are trapped within and those sentiments, those fears, those worries that live within us. Often when we hold really tight to them and we don't find a way to express them either out loud in words, on the page, through music, through artwork, they get trapped within us, they grow and they fester and they turn ugly into these monsters Dr. Hall was talking about that can hold a lot of power over us. So by simply having an outlet that you find that feels safe to be able to talk about it and find those words can really help to relieve it. And that listener doesn't have to necessarily have answers. And I say this as much for the talker as I do the listener. I think as someone who's on the receiving end of news like this or in having conversations with someone who's going through something difficult, it can be hard to resist the urge to provide solutions or to want to try and fix or solve. That feels like something we can do, but so much of this is unfixable, unsolvable in these moments and with just the general population. So sometimes it's just about providing space to hear and hold space for what that person is feeling. And that person just needs to hear, I hear you. This really sucks. That sounds really hard. And so again, sometimes people need to be reminded of this. And as the talker, you might need to say, listen, I'm not in a place where I need solutions right now. I just need to be heard. I just need to word vomit. I just need to talk about this. And I just need you to hear it. And retelling your story can certainly help you process some of the experiences that you've had, and telling and retelling and finding nuance and empowering yourself in the ways that things went well and processing the ways that didn't go well. But this is also exhausting energetically, emotionally. So finding the right time, space, and bandwidth for that is important. What I often tell people is to consider writing out little scripts for those interactions that you can anticipate. Maybe you're approaching a family event or a holiday or a trip, or know you're going to be seeing people you haven't seen in a while, or maybe not. But there might be opportunities you can anticipate, questions you can anticipate. And by practicing a little bit, whether by writing out a script or role playing a little bit with somebody in your household to figure out how those conversations you'd like them to go, even just starting out by role playing that conversation and realizing, oh wow, that's what came up when I tried to explain that. I haven't really thought it through, and maybe there are different words I'd like to use or different phrasing or a different amount of information I'd like to share. So by practicing it, writing scripts can also be a really good way to reduce the amount of burden on those conversations by simply copying and pasting into email threads, text threads, so you don't have to engage so much energy in order to start those conversations from scratch each time.
I think some of those things that you're saying are also true for the caregiver.
For sure.
I wouldn't say in front of my husband.
For sure.
But my best friend, she heard it all. Because I didn't want him to know what I was worried about. But I could cry with her.
Right.
I wouldn't do that. I wouldn't dare in front of him. No, I wasn't going to show him. But I'm scared of what might happen.
For sure. Yeah. Finding out those moments and those outlets for vulnerability, which may be different depending on who you're talking to. Some people also use social network pages to help organize some of the updates that they disseminate on a regular basis to people. There's a wonderful website called Caring Bridge that helps you organize the dissemination of information and can help to organize some of the help around the things you might need. Certainly closed Facebook groups can be helpful as well. So boundaries are so important. When we talk about how we talk about this diagnosis, how we get support from others, how we give support to people, both in, again, the giving of support end and the receiving of support end. So when you're talking with people in person and they're asking you questions and you're worried about the level of questioning and the line of questioning and where those conversations might be going, it can be tempting to want to try to sort of go into all of it in anticipation that they're going to ask you more questions, when in reality, they may have one or two questions and then be done. And you might miss an opportunity for, sort of preserving some of that disclosure and that privacy by sort of going full hog and answering more questions than they've asked. So you might start by giving people just enough information you feel they need, just enough for what the question is that they're asking, and then pause, see what else comes up. And you might find that the conversation goes less in depth than you thought it might, and there might be more opportunity, more desire from your end to share more, which you can take, but you can also cut that if it feels like it's, not the right time or place. Trying not to assume too much where people are going. Certainly screening calls, letting calls go to voicemail, answering, texts and phone calls and emails on your own terms. People don't need to be fully receiving your attention all the time immediately. It's okay to respond in your own time and on your own terms. And certainly, I say this so much, if a person is not adding value positively to your situation, they do not need to be involved. And that is a really hard boundary to set with some people. And you're going to have a better sense for, in your life, in your network, in your family, who are the people you can rely on for what, and being able to exert some of those boundaries around the people that might not be able to participate in a helpful way. Hard, but so effective. So just some examples of ways, some wording that can be helpful. So, for a lot of people, they have an outpouring of support in ways that might not be actually helpful. Maybe people showing up to the door with casseroles, or, calling day after day, asking, what can I do? What can I do? If people offer you support in a way that's not helpful, try to be thoughtful about the things that might actually be of assistance to you right now, and try offering an alternative. Thanks so much for offering to bring over dinner, but I'm good on casseroles. What I really need is somebody to come walk my dog tomorrow, or somebody to drive my son to soccer practice while I'm at my appointment. And can you help with that? If you struggle to answer the question, what can I do? Is there anything I can do? Please let me know what I can do. Maybe try responding with, just knowing that you're thinking about me is enough. Especially for those people who are offering, but in the back of your head, they're not really the person that you want to be calling upon, but it's important to them that they feel needed and they feel useful and they feel helpful. Just knowing you're thinking about me is enough. Thank you so much. And when somebody says the wrong thing, which they absolutely will, people say absolutely the wrong thing with the best of intentions. Try finding opportunities to speak up, of course, with kindness, but with authority, to let people know, I know you meant well, but that thing you said the other day, that kind of hurt my feelings. I didn't love the way it made me feel. I know you didn't mean it, but here's what I heard in what you said. And maybe the next time this comes up, maybe you could try approaching it from this direction. And often these conversations can be most helpful in the aftermath, not necessarily in the heat of the moment, but finding some time, a few hours, a few days, a few weeks later. You can always revisit things. You can always go back and say, I wanted to talk about that conversation we had the other day. Remember when you said that? Kind of made me feel bad. And I know you didn't mean to, but here's what might help the next time this comes up. So it can be really easy to shut people out who you feel like don't get it. And of course, we just talked about boundaries and exerting some of them. But on the flip side of that, sometimes it can be important to find ways to stay open to the people in your life who do add value, and trying to let them in, finding your voice and being able to let them know what it is you need, what it is that you're worried about, what it is that you're struggling with, and being able to speak up also if you feel like people aren't showing up enough for you. I feel like every time I give a talk like this, I have at least one or two people who say, but what about the fact that people have stopped asking me about this? I went through this a long time ago, and I'm still in surveillance, and I'm still worried, and I'm still scared, and it still affects my everyday life, but people have stopped asking. What do I do about that? And being able to find the words to overcome that feeling of, well, they should still be asking. People should know what I need. People should be able to tell that I'm still upset and that I need something. Being able to overcome that a little bit to be able to speak up for yourself. and invite them out to lunch. Let them know, I've been feeling really lonely. I've been feeling really neglected. You know, let's make some plans to be together more often. Here's what I need. Also notice who tends to show up and who tends to step back. These sort of events in your life are going to be really telling, and they bring out the best and the worst in the people around you. And some people may not be able to handle it. They might not be able to be there for you in the way you might need them to. And noticing that and trying when you can to work with them if they're somebody that you really would like to have around in a certain capacity, but also being able to recognize what value certain people are capable of holding in your life in terms of talking about what's going on. Certainly considering if you don't have people that you feel like are showing up for you in the right way and you're feeling really isolated, go out and do the things that you like to do that bring your life value and joy, and have conversations with the people around you, not even necessarily around the cancer, but by going out in the world, doing the things that you like and talking about normal life can help you feel less isolated, can help open the door of confidence and self-assurance in you to be able to find the words to talk about what's going on as well. Certainly answering medical questions in this scenario from the people in your life when you don't know the answers either, super stressful. And it's normal and okay to feel stressed and anxious about the uncertainty and about answering those questions. So when people in your life are asking questions medically that you don't know the answer to, you could try some of these responses. I don't know right now, but hopefully I will soon. I'm not ready to talk about that right now. That can provide a really hard stop on a conversation, and people might bristle a little bit to that, but it's really effective. You know what? Thank you so much for asking. I'm just not really ready to talk about it. And I'll let you know when I have more to share. I think that's a really good one, so people feel like you're not keeping them out, but you just don't know. But I promise I'll let you know when I do and when I'm ready to tell you. Bringing a trusted family member or friend with you to appointments to help absorb some of that information so that when loved ones are asking later, you don't have to rely so much on your memory as a patient, but sort of together, you can absorb the information, figure out how to process it, debrief together after the visit about what all this means and how we're going to answer those questions from the kids or from the neighbors or who else. And being able to share that burden a little bit can be so helpful. We often talk about cancer as a family illness, meaning that not everybody is going through the scans, getting the treatments, going to the appointments, but everyone is affected by it in their own way. And subsequently, everyone has a different coping strategy. Everyone has a different timeline for acceptance. Everyone has different behaviors that help them manage stress. And so when everyone in a family unit is existing in the same household or the same social sphere with different coping strategies, different timelines, and the same stressors, it can create a lot of distress, a lot of shared distress, a lot of individual distress, and figuring out how to navigate that, how to support someone who's on a totally different plane than you when you're also struggling in your same household. It's really challenging. And different education levels, different levels of interest in knowing what's happening in the same household. It can be hard to find the words to know exactly how to keep everybody up to speed. Certainly, illnesses rarely fix or resolve long-standing family issues. It can provide an opportunity to find some additional healing, some space to bring people together who might not have chosen to be together before, but those dynamics are often still going to be at play. And so finding the words to be able to, again, exert some of those boundaries, recognize that we're in a situation that people are not used to being in, and some of those old patterns and old dynamics are rearing their heads, and having sort of space and, time to process and find some healing around that, and to take care of ourselves around it too. What is it that I need in the context of this environment? A little bit about talking with kids, so challenging. They're so smart, they're so perceptive, they're so observant. They pick up on everything. They pick up on the tone, on the information, in their own way. And they're understanding a lot more than a lot of people give them credit for. And so when they're asking questions, it's so important to try and answer them as honestly and age appropriately as makes sense for what's going on. Trying not to, keep them in the dark, because they're going to pick up on the fact that there's information that you're not telling them. And they're going to create in their mind a scenario of what they think is going on in the absence of your answers that is often way scarier than what might actually be going on. They also might place a sense of blame or responsibility on themselves, which we can look at them as an adult and say, this is not your fault. But in their mind, it might feel that way when they're not being talked to. Check in with them often, ask them if they have questions, find out if they have an outlet for support, even if it can't be you, and often it can't be. But asking their school about mental health support, encouraging them to talk with a friend, make sure that they're talking to someone, even if it's not you, and reassure them without making promises you can't keep, which is often very, very challenging. Will you get better? How do you answer that question to a child? I sure hope so. I trust my doctors. We're going to do everything we can to help me be well. Gives them enough information and security, but it leaves open the possibility that later on, when they look back on this conversation, they can say, oh yeah, but they didn't necessarily say that I definitely would. We're not making promises that you can't keep. I breezed through that very quickly so that we could catch up. Lots always more to say on this. I just want to empower anyone watching this that it is possible to find the right words. It might take some time and practice and trial and error, but you've got this. I don't think we have a lot of time, but does anyone have any questions or reflections? Thank you so much.
We all forgot it. Just want to make sure.
Hi, thank you so much for the invitation to be here with you today. And I am going to talk about a topic that is often not addressed and talked about. I think we're a small, oh, I need to be here so I can move it because I was going to say I was going to just stand out there and not use the mic. So a little bit about my background. I am a clinical psychologist. I've worked in the field of psychosocial oncology for over 30 years. I'm at Dana-Farber and I oversee there the young adult program. I've always had about 50% of my patients throughout my over 30-year career that were young adults, but then the other 50% were not. And for about 25 years, I've also focused on the sexual health of our patients. And I realized, 25 or so years ago that this was just an area that was not really discussed. And yet, we all have sexual thoughts and it's part of our life. And yet it was not something that was being addressed. So all those years ago, I went back, I got trained, and I see patients individually and sometimes as couples. And so I wanted to make that point because what I'm presenting about today is very general information and just important to keep in mind that I always tailor it to the individual and the couples. No financial disclosures. So sexuality after cancer. And one of the things that people always wonder is why are these possible side effects that are so common not discussed? And it really does make sense, right? In many ways, because when you first get diagnosed, the whole focus is on getting treated and saving your life. And really, those sexual thoughts are not going to be on your mind all that much because you just want to survive and you're terrified. So it makes sense that they're not going to do that early on when you're diagnosed and starting treatment. Part of it too is that there's that very limited time during visits. So it's also hard for the oncology team to find the time to discuss it because there is so much going on. And we also know that healthcare professionals do not feel comfortable talking about sex. They're also very worried that if they ask you a question like, has there been a change? Then you're going to have lots of questions and you're going to go on, and they don't know how to answer. And then they may not know or have the place to refer you to. But that's an interesting one because even at Dana-Farber, where there's a director of sexual health, and then I do the young adult sexual health. So there are people there. The patients don't get asked either. So it's not just the referral. I think it's that there's really, again, that discomfort. They've gotten a lot better if you're young at least focusing on the fertility part. And they sometimes say, well, we asked about fertility. They're, 35 or 40, and we asked about fertility. And it's sort of like, yeah, but fertility and sexuality are two different things. So again, the sexuality part is still an issue. And so we also know that if the healthcare professionals don't bring it up, then usually patients don't bring it up. And so there's also the focus that if it's a body part that's associated with being sexual, so if you have prostate or gynecologic, maybe they bring it up, or more likely. But again, if it's not perceived that way, then, they often, again, just never discuss it. I would say that probably when we do these polls, when we do some programming at Dana-Farber, we do these polls where we ask, did anybody in your healthcare team ask you or discuss sexual health? And we get anywhere between 50 to 75% where it was never discussed at any point. And again, we have one of the most robust programs in sexual health in the country, yet it's not happening. And the reason I think that we get that sometimes, depending on the group, 25% who do or 50 is because they have prostate, they may have breast, they have a gynecologic. And if that group, then they do get asked, but not a whole lot there in terms of the follow-up afterwards. So when we tend to think of your sexual life or anybody's sexual life, we really look at it from this biopsychosocial model. You can't really just look at your sex life here and it's out here. It's really part of who you are, part of your overall life. And so you really do need to take into account, for each individual, what is their diagnosis? What treatment have they had? And then based on that, the impact that it can have on them as, again, in all these things, what impact does it have in terms of their body image, in terms of fatigue, in terms of pain they may have? So you really need to see how these different variables interact with each other. Obviously, if somebody's really anxious or depressed, not just a little bit, but very anxious or depressed, well, that's going to interfere with your sexual desire, wanting to be intimate, if you're too stressed out. So even before cancer, we all know that if we just get so stressed out in life, sometimes we don't attend to that part of our relationship. And it happens. So with the additional stressor of having to go through treatment, of course, it's going to be very hard. With some of the targeted therapies, people may get a rash or they may get GI symptoms. And so that's going to have an impact. And then we also look at the cultural and social and religious variables. Important to take that into account. So when I see somebody, many times people will say, this is the way that I was brought up, or this was, within my upbringing and my religious upbringing, this was just never discussed. The only thing was really, maybe abstinence. And then I got married, and then, it was, I've never had any other experience, and now I got diagnosed and I don't know what we should do. So again, and then you have other people, of course, where it's a very different experience. It was very open communication. And then, we look here also at, we have so many people from different cultures and their views that they may have on, what it means to be whatever gender and how that feels. And so, and again, included in this model is also, people that have different sexual orientations, different genders. So all of that goes into account when I see somebody individually. And sort of my intake when I meet with somebody sort of covers these topics in detail on that first visit. And so again, this is a different way to look at the other slide. It's a different way, but all of these variables are going to impact, right? So if you're really fatigued, that's going to have an impact. If there's relationship issues that were there before or new, that's going to have an impact. So all of these variables impact each other. And I really want to stress again the whole part about anxiety and depression, because that really can have such a huge interference, in a sense, in your life across the board, with your sexual life being part of it, and the importance of really making sure that you attend to that part. I think that what I tend to see with some of the younger folks I see is that there is much more openness to getting care for your emotional well-being. Whereas I think that other generations, it wasn't as open. So it's been nice to see that push and that willingness to advocate for those services. But again, important to do. And I think for many people, the role of hormones and hormonal changes are not always taken into account, and how that can impact your mood. So for example, when you go through either premature menopause or natural menopause, which again, as women, there isn't as much attention to this in our society as there should be. It sometimes happens that your mood changes and you may become more irritable, or there may be some mood changes. And so that will have an impact, which can then affect how you feel sexually. Sleep, if you get hot flashes, for example, or if you're not sleeping well, that's going to add to fatigue. The whole treatment, if you have like rashes or weight changes or muscle changes, sometimes those things are going to have a lot to do with it, because it's how you feel about yourself. So when I see couples, sometimes, the partner will say to me, oh, so-and-so still, I'm still so attracted to them. But the person that's going through it says, but I don't feel that way about myself. When I look in the mirror, I don't feel that way. So your body image is that part of you. How do you feel about yourself? And that's going to have an impact. And then so many times the changes in our roles and relationships, if you're used to being the one who always takes care of everything in the house, or you're the one that's used to going out and working, and now you can't do that, then that's going to have an impact on how you view yourself, the impact it has on the relationship. And then I brought up the other ones before. And you're keeping track, right, Ryan, of the time? I'm going to try, but okay. I have half an hour or so. Okay. Yep. So because we're in a group, it's really hard to focus on those individual components that I was talking about, because they're so specific. So we're really going to focus more than anything on the body, right? And what you can do. And it's important, as I said, to really look at restoring your sexual health in concert with your overall health and well-being. But we're going to address more than anything like the mechanics. For example, with men, talking about maybe erectile changes. With women, talking about natural menopause or premature menopause. And then, those medical factors that are so different. Again, we're going to talk of those in terms of general recommendations and lifestyle changes, but those we usually, again, tailor to each person. So it is not unusual for there to be a change in sexual functioning for men throughout life. That's just going to happen. And it may happen at specific points. It may happen just throughout, that there's a change. There may be peaks and valleys. It changes. And I think that so often it's something that's hard for men to talk about. And there may be changes in desire. So, for men, just that stress, when you're so scared for your life, And I think, as Dr. Hall was saying earlier, you're in fight or flight. You are terrified. What's going to happen to me? You're not going to have sexual feelings, because if you look at anxiety and the function of anxiety in terms of evolution, it's to keep you vigilant. It's to have you looking for a possible threat. So when you're in that state of heightened arousal and scared, being sexual is counter that, because if you did, then in a sense, being in a sexual act is a very vulnerable position, and it's counter to that vigilance of letting your guard down. So, it's really important to keep in mind that it is perfectly normal and expected that there will be changes in desire and change in erectile function throughout cancer treatment. And I always say that one of the earliest examples I have that got me to get the training was a young guy. He was 26, single, with Hodgkin's lymphoma. And he came to see me for depression. He was referred for depression. And I remember meeting with him. And as I started to do my intake, he basically said, I've lost all sexual desire. And a big part of my sense of identity is being a sexual being. I'm 26 years old. I find that I am not attracted to anybody. I've tried pornography, nothing. It's like there's no desire, there's no erections. I just find like this is not me. So I'm depressed. If this is what cancer has done, and this is what my treatment and after treatment is going to be like, then, I am really depressed, like what's going to happen to me? And I remember telling him, this is normal during treatment. It happens pretty much to everybody, regardless of age. And, if after you finish treatment within 6 months to a year hasn't changed, please come back. And, we went through some other things. Never came back to see me. And then I saw him one day, in the waiting area, and he was just like, you were right, I'm back. And I was like, great. But, it's that whole thing that nobody talked to him. So of course he was depressed. So again, totally normal. Now, if you do find that, it's been now quite a while, the type of treatment that you're on is in no way affects your hormones, and that shouldn't be the case with any type of, melanoma. So it's always good to check your testosterone levels. And so that can be checked. And today, thankfully, there's many approaches that are there that can really help to bring up those testosterone levels. So part of it is desire. And so part of what the desire is hormonal. And so, as I said there, do check your levels, but there's more to desire than just hormones. And we'll talk about that later, but definitely have that checked. And there's interventions there on a medical level that are can easily be done. And then the other part is erectile changes. And so we know that a lot of the treatments can impact your ability to maintain an erection. And that is not at all unusual. And many medications that are not even cancer medications can do that. So there's many different treatments. And so I listed here the medications, which are the most common treatment. And I'll go through this in more detail. There's injections, there's vacuum pumps, and prostheses. So we're going to start at the bottom because that's the most invasive type of treatment. And so this is usually more than anything used for, men who've had a type of cancer that really makes it impossible. So we see this sometimes with penile cancer, where they do get a prosthesis. And I have seen, men with penile cancer. It sometimes is for men who've had prostate cancer, but it's a very invasive surgery. And again, there could be complications. So that's sort of usually a last resort, but, again, it's there. Vacuum pumps are pretty much what it sounds like. It's a pump. You actually put it over your penis, put an elastic at the base of the penis, and use a pump that basically makes sure that an erection takes place. You remove the pump, and for a little while, the erection can be maintained. Not the most effective, not the most comfortable, but again, an option. The one that actually works the best are the injections. And these injections are the ones that are terrifying for men because it's the idea of putting, even though it's a teeny, teeny needle and very thin, the idea of putting that on the side of the penis terrifies men. So, but it's usually done in a way where once men have practiced, and usually they'll practice because you'll get the prescription in a urologist office and you can practice there. Most men report that it's a lot more psychological than really anything that they feel in terms of pain, but it's that fear. The injections are extremely, extremely, successful in getting and maintaining an erection for a period of time, half an hour, an hour. And it happens pretty quickly after you've done the injection. But again, I think that it's that fear, that psychological part, which is understandable. But, I want to just say that they are, in a sense, the one treatment, that it's most reliable, that it's going to work. And you're going to be able to get an erection every time and maintain it. So reliability, and it's going to be there. Now, the one that most men will go to are medications. And that's usually the first line. Because it's easy and it makes sense. It's easy. So I listed here the common medications. Viagra is the first one that came out on the market. Everybody knows the little blue pill. And then other ones have come out afterwards. So I made this chart to sort of show, how long you need to take it before being sexually intimate. And if the goal is intercourse, when you should be able to maintain an erection, and then how long it lasts. If you'll see there, Cialis really lasts the longest. And the nice part about it is that you can take it and there isn't that sort of pressure that I have to be sexually intimate soon because it's going to wear off. So you can take it and, it could be an hour or 2 hours. There's some ability there to relax and not feel that pressure about it wearing off. Viagra, a lot of men say that it's, 4 hours, some 2. So there's some variability there. It is still the most commonly prescribed, but I think Cialis is just a better drug all around. It came out later. And, you take the drug and if the man isn't stimulated, then there won't be an erection. So it's not like you take it and you get an erection. It's like you take it and then there needs to be some stimulation, physical and mental, in that sense of cognitively having the sexual thoughts. So, again, these are some of the things that can be done very much in terms of the mechanics, the physical part. But I would say that when I see people, the mechanical part may have started the problem. So there was usually something that happened because of treatment that interfered with the ability to have an erection or maintain it. Anxiety, fear that may have been going on, and they tried anyways. And now you get into where you may develop some performance anxiety, or there's this psychological distress we talked about. Or, just like women may say, I don't feel that great about my body and my body image. I hear this from men all the time. Like my sense of masculinity isn't there. My muscle tone isn't there. Either I'm too thin or I'm too heavy. I have this rash and I look at my body and I don't like how I look. So, these targeted therapies that work so well now are great, but they do often result in these rashes and unusual side effects that are difficult to deal with. And then there's always the relationship dynamics. I often hear from partners that they're very concerned about bringing up anything sexual because first, they don't want to be insensitive. First, they don't want to hurt the person. So are they not feeling well enough? So if they're not feeling well, it's maybe inappropriate to bring it up. I don't want them to feel pressured. Is it selfish of me to bring it up? So again, the relationship dynamics are a big part. And that's why I said that when I see people, I usually do at some point talk to the partner, if there is a partner, because it's important for them to know that so much of what may be happening has very little to do with them. And it's really related to the treatment. we're going to spend some time talking about women. So one of the things that I think is really not talked about in our society a lot really is menopause and some of the changes that can happen in menopause. For some, women going through cancer treatment, depending on the medication you're on, it can result in premature menopause. So there's a lot of, variability depending on what treatment you're getting. But again, whether it's premature or menopause, what happens in women's body is that there's this decrease in estrogen and testosterone. Women do produce a small amount of testosterone in the ovaries as well as the adrenal gland. So during menopause, there is a major decrease in those levels. And we today look at menopause as a genitourinary symptoms that impact sexual health. It's not just the sexual part. There is a part here that also involves your urinary system. And I'm bringing this up because have any of you seen on TV these commercials that are for Poise or these types of pads for urinary incontinence for women? And so again, it's just like, oh, we have these special pads. That is because for many women, as a result of menopause, as the years go on, they do start to report that they may have some urinary incontinence. It may be when they laugh, it may be, when they cough, they may have some leakage, or they may just develop difficulty where they have to go a lot more often and are having difficulties really emptying the bladder. Part is that estrogen does have a role in all of those organs in the area, in your pelvic area, and they provide elasticity and it provides flexibility in that whole system. So that is the way we look at menopause today. And so I said here, it can be temporary or permanent depending on your age. And one of the main symptoms that occurs initially is really this vaginal dryness. And vaginal dryness can then result in pain, a feeling of tightness internally. There's reduced elasticity. There's a change in blood flow and sensation to the vagina. So that is part of what happens when you go into menopause. And then hot flashes, changes in mood, which I talked about before, are not unusual. Fatigue. Even women who go through natural menopause will report that their energy level is not the same. And as we talked about, that's going to affect desire. If you're still like, menopause happens on average at 52, you're still young, and now you may have a lot. You have aging parents, you have kids, you have a job, you have cancer treatment. I mean, fatigue is a big part of it. And now the hormonal changes may add to that. The hot flashes can cause sleep difficulties. And then there's cognitive fog, which happens through natural menopause, and treatment, as you all know, can also cause some, cognitive changes. And then, of course, there's the decreased libido or desire. And again, just like I said with men, with women as well, desire is not just the hormones. So if you go to menopause or premature menopause, you want to check your hormone levels to make sure you are in menopause. And so here, if you do not have a cancer or a condition where taking hormones systemically is problematic, you should go ahead and do it for women. You need to talk to your gynecologist, but taking systemic hormones is not what was thought of in the past. This is very, very dangerous thing. You need to talk to your oncologist. You need to talk to your gynecologist, because again, some people may have tumors that are hormone sensitive, not usually the case with melanoma or ocular melanoma for sure, but you never know. There's sometimes these genetic predispositions and situations like that where you need to be careful. But if not, and the symptoms of going through menopause are severe and really interfering with your well-being, then do talk about getting on a systemic hormone. Systemic, I mean throughout the body, whether it's a patch that you wear or pills that you take, it will then replenish, that estrogen that is really lacking at that time. And then there is a way that you can taper it as you get older and your body sort of finds the balance. So let me just go back. So systemic, oh, wait. Systemic, where am I going here? Let me go. I'm trying to go back. Okay, so I just want to say systemic hormones will definitely help your vaginal health. They will definitely increase moisture in your vagina and lubrication, but probably not as much as you would like, given where you were at before menopause. And so there's 2 steps to vaginal health. There's maybe more, but 2 major steps. The first thing is you need to, whether you've gone through menopause naturally or not, you want to make sure that your vagina maintains moisture. And so you need to moisturize your vagina. This is not something you think about before menopause. You know, usually, again, there may be conditions where you do, but in general, it's not something you give a lot of thought to. It's like my vagina is fine. I don't have to think about it. You go through menopause or any treatment puts you into temporary hormonal changes, and you need to start thinking about it. So what I usually recommend is that you need to use a vaginal moisturizer. And if it's an over-the-counter, not a hormonal one, but an over-the-counter, such as Replens, and I put up that picture because it's the one I like. It's available everywhere. It's inexpensive. So you need to use it every other night before bed. It's not something that you're going to do once in a while. This is not about being sexually intimate. This is about your own vaginal health and keeping your vagina moist. So that is about buying it, and it comes in a pre-filled applicator that looks sort of like a tampon. You insert and you squeeze, or you can buy where there is a refillable applicator and you fill it in. It needs to be done before bed so that you have time to let it be absorbed. And you then take some of that moisturizer and apply it externally as well. Again, I'm going to go back. If your vagina is not moist, it'll get to a point where having a gynecologic checkup will become extremely uncomfortable. You know what? Riding a bike can become uncomfortable because you have dryness. Wearing tight yoga pants can become uncomfortable. So all of those things. So you really want to keep that moisture internally as well as externally. You do need to put some on your fingers and apply it liberally externally. You want moisturizers that, again, are water-based, glycerin-free, and there's many out there. I put their Replens. Reverie is one. There's many out there. And so usually I ask women to try the one that's available on Amazon everywhere, Replens. If that doesn't work, then we have a list. And again, most financially, it's the least expensive. Now, if that doesn't work and you actually want something hormonal, you could just talk to your gynecologist and get on a topical hormone, whether it's an estrate vaginal cream, whether it's Vagifem. There's very many different types of inserts that you can use to apply topical estrogen. Topical estrogen has been shown to be just that, topical. It does not show up if they do blood work circulating throughout your body. So again, even if you don't want to use the systemic hormone, you may decide, hey, I'll use the topical one. And today, gynecologists are very, very comfortable, prescribing that across the board. So that's step 1 for vaginal health, moisturize. Number 2, in terms of moisture, if you're going to be sexually intimate, you need to now use a lubricant. Even if you're using a moisturizer, hormonal or not, when you're going to be sexually intimate, if you're in a heterosexual relationship or not, you use toys, anything that involves penetration, you are going to need to use a lubricant to lubricate it. That means that if it's with a man, then you're going to need to put the lubricant liberally on the penis. If you're using toys, you want to put the lubricant on the toys. So, and you may need to reapply it during that sexually intimate act. I listed some here. My favorites are, I put KY because it's what everybody knows. It's my least favorite. I put Good Clean Love because that's what I really like. and you need to use the one that says lubricant. And I like Astroglide too. Both are available everywhere. And so we have those, like if you go to our Dana-Farber, we have a little shop for women to, well, I shouldn't say women, for patients. We have those available there. 2 minutes. Okay, let me go quickly. So for dryness, again, those things to avoid. Equally important for vaginal health, pelvic floor. So remember what we talked about in terms of that, urinary part? It's pelvic floor that's going to help the vagina to stretch, and it's what's going to help you to avoid urinary incontinence. So you need to see a physical therapist who specializes in pelvic floor, limited number, often long waits. So you need to do that. They will help you if you need to use dilators, but they will do a pelvic exam and they will tailor their physical therapy for you. Critically important. I think more and more young women postpartum are starting to do this too. So there's a huge demand. And then to increase blood flow, vibrator therapy. So usually after you've done the other two, I really encourage women to get a vibrator, couple 2 to 3 times a week, engage with the vibrator for a few minutes, see what feels good, see, the speed, see what works for you. And then again, I said this because it's the most studied group are breast cancer patients. But again, if you've had a painful experience being sexually intimate, your body is going to contract. That is just the case. This is even if you're not menopausal, that's anybody. You've had a painful sexual experience, you contract. That means your vagina muscles contract. So that fear and anxiety then gets you to avoid it, which results in less sexual activity and decreased desire. Who's going to want to be sexually intimate if it's been painful? Pelvic floor really helps you to know how to relax the muscles and what to do. That's a whole other talk that I have on, dating while going through treatment and sexual intimacy. These are quick. So enhancing your sexuality and intimacy. We look at desire no longer as something that's spontaneous and automatic. Desire is really something you cultivate. Other than when you're early on in a relationship and it's like, you just want to be with that person. If you remember that time, you were consumed with that person. You can't stay in that state forever because you wouldn't be able to function. So at some point, things change and you're not in that constant state of arousal. And so you really need to communicate and make time to be sexually intimate. This means communicating with your partner. If you're being sexually intimate, the goal is not sexual intercourse or to get an erection. Maybe focus on pleasure, make time for intimacy. Even when you're going through treatment and may not have the desire, everybody likes to be touched, hold hands. I often say here, you know what? Go ahead and read maybe some erotic literature, or just get a book and read it. Sort of tune into that part of yourself, watch an erotic movie. I have like a whole list that I send to people of movies or things you can read, but it is so individual. What is erotic for one person may not be for another. So I always love listening to what people tell me. Listen to music, dance, kiss. It doesn't always have to be, sexual intercourse. And I think that's one of the things that really gets people to avoid sexual intimacy is that if I start, it has to reach this point. And I'm sort of saying, if you're going through treatment and you're not up to getting to some goal, just be together, take a tub bath, take a shower, really do communicate if anything is uncomfortable. But again, focusing on what feels good versus having a goal in mind. And this is a lot of where I give homework to people and I ask them to do things, really keep an open mind, experiment with different positions, experiment with different ways to be intimate. And I sometimes just leave those with question marks because people always ask about medications and things like that. And then this is the end. Just really acknowledge if there has been a change and a loss in terms of who you are and how you perceive yourself as a total person, which is going to impact how you view yourself in relationships and sexually. it's important to acknowledge those changes. You can't ignore it. You can't say, oh, everything's fine. It's not. Changes have happened. And find ways to cope with those, ways to deal with those changes in body image. Because again, we go back, so often it's about how you feel about yourself. The things you say to yourself, sometimes we say such horrible things to ourselves as people. I usually say women because it's so much a part of our society that we hear this negative talk about ourselves and our bodies. I think it's changing some, but I also think it happens to men a lot too. There's certain expectations that men have about their bodies and how they should function. And so, whether it means, buying new clothes, adjusting to those body changes, attending to your mood, your sleep, hard to be sexual if you're just sort of, exhausted. And then exercise is probably one of the best things you can do because it really changes that relationship with your body. It can help you to feel stronger, but it also helps with anxiety and depression and so many other things. Those are just our resources at Dana-Farber. Those are general resources, and that's it. So if you have any questions, let me know. I'll leave that slide up because it provides a lot of different resources. Thank you very much for having me. So, does anybody have any questions? I usually don't get questions in an audience format, so it's really funny. Our best attended, so we have like an app for our young adults where it's like a Facebook Live, but ours is iAlive. And so that is our best attended because people just have like any identification they want and it's safe. It's only for our Dana-Farber young adults. And then I get flooded with questions and huge attendance. But when it's things like this, nobody wants to say anything, which is fine. So just thank you so much for having me.